I'm Yu Ying. I'm one of the first year GI fellows. I will present a case that I did on consoles a couple months ago now. So I have a 30-year-old female, no medical history, presents with a sensation of food being stuck in my chest. She had rice and fish about approximately 24 hours ago with some sharp chest pain that she developed right after. She then went to a local outside hospital where she ended up just getting a CT scan, which showed no radio-opaque foreign body, and then was discharged from the ED. But she came to our ED instead because she had persistent chest pain. At the time of evaluation, which was right around 4 p.m., she was well appearing in absolutely no distress, but still said, drinking water still made her chest hurt. So we took her for an endoscopy at that time. So I have a little video to show, which may have spoiled it. I cut down this significantly. What you won't see is Satish coming into the room, coaching me through this. So what you'll see is when we went down, we were very surprised to see a fish bone stuck in her mid-esophagus. There was some debate at the beginning of this case whether or not we should use an overtube, but Satish very confidently coached me into sort of just using forceps to grab it. You won't hear him, but he's like calmly coaching me through using my dials to carefully pull it out. Yeah, and then on the next slide, hang on a second. On the next slide, this is sort of our second look when we went down. And you can see just a little tiny area of mucosal irritation right where we pulled out the fish bone in the mid-esophagus, but overall, the exam was otherwise completely normal. We actually discharged her from the endoscopy suite with 7 days of antibiotics. I called her a week after. She had absolutely no symptoms and was doing very well. And I was, told her to avoid fish with bones going forward. So today for Endoscopy Conference, I just wanted to talk a little bit about foreign bodies. I feel like, we as first years get a lecture every now and then when you see it, you kind of remember some of the principles, but it's always one of those overnight phone calls that I end up pulling up this slide, this table very often. So this is from the ASGE guidelines on managing foreign bodies and food impactions. And the need and timing for intervention for foreign body obviously always depends on a patient's clinical condition, the size, shape, content, and the anatomic location of the ingested object and time since ingestion. If it passes to the stomach, most foreign bodies will pass within 4 to 6 days, and conservative management is preferred in those cases. However, if a patient is unable to manage their secretions, then it requires emergent endoscopic intervention to avoid aspiration. Ingestion of disc batteries and sharp and long objects also increase the risk of perforation. The majority of sharp-pointed objects in the stomach, which I found interesting, will actually pass without incident, but the risk of a complication is still as high as 35%. So even a sharp object that has passed into the stomach or proximal to duodenum, we should still try to retrieve it endoscopically if it can be accomplished safely. Otherwise, they advise that sharp-pointed objects can be followed with daily radiographs to document their passage. And then surgical intervention should be considered for objects that fail to progress after 3 days. So one thing that I wanted to look into, mostly because I've done a couple of food impaction cases and foreign body cases, but haven't actually used an overtube, is looking into more the data or lack thereof of using overtube for foreign body retrieval. So just as a brief overview, an overtube is a sleeve-like device designed to facilitate endoscopy, and they all have an inner diameter that's larger than the endoscope, providing a conduit for passage of the device into the digestive tract. They're intended to protect the GI mucosa from trauma and limit the risk of aspiration and facilitate access in patients with challenging anatomy, increasing the depth of insertion and maintaining access if we have to end up going in multiple times, as in the case of some food impaction cases. They vary in length and in caliber to correspond to the intended applications and routes of entry. And to protect the esophagus, when objects are removed from the stomach, it should be at least 50 centimeter in length. And then something I didn't realize was that there are also overtube devices that are designed specifically to facilitate deep endoscope insertion to reach portions of the digestive tract that is not traditionally accessible with a standard upper endoscope. And there are specific devices that are actually marketed as part of an entire enteroscopy system with an accompanying enteroscope. So, you know, despite a very deep dive into the literature, the best thing I could find on sort of data on overtube use and is this ASGE technical review that dates back to 2009. And basically, you know, in this technical review, they suggest these are sort of the most common indications for overtube use in endoscopy. And they do say that foreign body removal represents one of the most common indications for use. I went back to actually the studies that they cited, and these studies are all retrospective, sort of descriptive case series or reports of using foreign bodies with an overtube system dating from 1974, which was the first case report with razor blades, to 1995. So there hasn't been anything really more recent other than like sort of single case reports. The major advantages in this review that they cite is of an overtube includes prevention of esophageal mucosal injury and aspiration. And if there are numerous objects that need to be extracted, the overtube can provide a conduit for sort of repeated endoscopic insertion and withdrawal. Interestingly, this review also describes some of the data for using overtube to complete a difficult colonoscopy. There were some case series that they talked about, including one with 8 patients who had failed colonoscopy secondary to excessive loop formation, and then the shape block device, which was one of the overtube device they talked about in this review, was used for successful cecal intubation for patients. However, they do cite that the mucosal injury rate in that case review was about 3%. So the most common complication in technical review that they talked about was abrasion and tears. But what I found really scary and a little disconcerting was sort of the other significant complications they talked about, which include pharyngeal and esophageal perforation, a case of variceal rupture, overtube separation, transient vocal cord paralysis, pneumomediastinum, and tracheal compression. And in the case of that sort of deep enteroscopy overtube system, it can also, in one case, cause pancreatitis because of prolonged compression on the ampulla. So sort of my take-home points and a launch pad I hope for some discussion is that, you know, removal of foreign bodies is one of the most common indications for overtube use, and that facilitation and for deeper access in small bowel enteroscopy and completion of colonoscopy may become an emerging indication. It can be associated with serious adverse events, but there are very, very limited studies on comparative analysis on the impact of overtube use. So I was curious to hear the group's thoughts on what their practice is, just because I feel like from my experience, it's obviously very attending dependent. Thank you.
That's a great case, Yu Yang. There's so many things we can talk about. Thank you for presenting it. I think one thing we should point out was your technique was perfect. The sharp edge or the sharp point was the trailing point. So as you were withdrawing the scope, the pointy edge of that bone was pointing downwards, so you would minimize trauma. And that goes for any kind of sharp object, other kinds of bones, safety pins, that sort of thing. Just another sort of practical point about foreign bodies, just because I had this conversation with Dave Greenwald last night. When in doubt about a foreign body, if it's something you can find easily, it's cool to just take it and practice on the tabletop with various devices to see what will work. Dave was telling me that he took out a spoon, or you guys took out a spoon from someone's stomach last week. And you can practice with the spoon on the tabletop before you start flogging around in the patient to figure out what is the best device that'll do it. And then before I open it up for questions and comments, just one practical point about overtubes that is important to know, especially if you have limited experience placing them. As you mentioned, Ying, there's different lengths, but there's also different diameters. So if you have a large diameter overtube for a therapeutic scope, but you're placing it with a upper scope, a standard upper scope, there is a lot of space between the overtube goes over the scope shaft. There is going to be a lot of space between the scope and the overtube. And if you're not doing it correctly, and you obviously want to match up the diameter with the scope, but if you have a mismatch, you may catch tissue between the overtube and the scope, and you can cause some pretty bad trauma that way. So make sure you know what the diameter is in relation to the scope that you're using. So I will open it up for other comments and questions. Very cool case.
I wanted to speak to that tube mismatch thing because I've done it and bad things happened afterwards. It was one of the most horrifying moments I've had in endoscopy ever since I touched a scope. One of the ways to know about the tube and scope mismatch, the top of the overtube has got a color on it. It's either yellow or pink. And you showed that in your little slide a second ago. The scope has a label that says the model number GIF H190. That's the same color as the top of the overtube. So an upper scope has a yellow label and the top of the overtube is yellow. They're deliberately made that color for a reason. And so if you use the pink overtube, that's for a therapeutic scope. The therapeutic scope has a pink label on it. Don't mess this up because you will dissect the neck and the piriformis and that whole area. It's bad news. And you just need to make sure you've got that diameter matched up.
And the nurses, just to add to that, the nurses, the last time I used the overtube, actually showed me that before I showed it to them. So they're catching on to that also.
And just not to harp on it, but just for good endoscopic practice, if you ask for an overtube, depending on who your nurse, your assistant, your tech is, they may just grab anything off the shelf. They may not be familiar that there are different sizes and lengths. So it's important that you check it yourself. Your attending may not even be aware, depending on if it's somebody who is not rotating on inpatient service often or et cetera. So just be aware of that, and definitely make sure everything checks out yourself.
Why does the size have that effect? Like, why is it dangerous? Is it because you're something with the insufflation and that there's room, or what happens?
So the way these are placed is you have your scope outside the body, and then you put the overtube over the scope and you insert both together. Mm-hmm. If you are using a diagnostic gastroscope, a standard gastroscope, and if you are using a therapeutic sized overtube, there is a lot of space that allows the scope to rattle around within the overtube. Mm-hmm. And when you're pushing it down, in that gap of space between the inner wall of the overtube and the outer wall of the scope, you're going to catch tissue, like Satish, unfortunately.
Okay.
And you just pull it and shear it, and it causes a lot of trauma. It causes a big tear.
Got it.
Andy.
Hey, it's go ahead.
Oh, go ahead, please.
Just one thing that I wanted to mention is that I've used the overtube a lot with like Nani as a first year. For some reason, every time we were both on call, we always got food impactions. And one thing that he taught me, which I thought was very helpful, is that the overtube is really, really stiff, and it gives issues as you're trying to intubate the esophagus with that. And so a tip that he gave was to soak it in warm water for a couple of minutes before using it, so that it kind of becomes a little bit more flexible and more malleable. And it's worked really nicely the couple of times that I've done it in that way.
Cool tip. Andy, you got a comment?
That was a great case, Yu Yang. As a Taiwanese American, I remember growing up, and I hate fish with bones because it's like a rite of passage to be able to eat one. But I remember this, like, whenever you feel like something's stuck, they're like, eat more rice, and that's usually not the right answer. So, but I think that was, really great example of endoscopic expertise. And I think the way you guys removed it under direct visualization was great. And I think an important point was what Chris brought up. I think it was like Chevalier Jackson's axiom is what I recall Greg Ginsberg talking my brain. And it's leading points puncture, trailing points do not. And so if you can see it, that's great. If you kind of are a little less comfortable, or Satish is in bed and can't help you, I think a foreign body hood could help you there too. They're pretty cheap, widely available. Yeah, this one is a little tougher because it'd be hard to actually get the hood to kind of expand out, but if it was in the stomach, I think that'd be great. I was going to comment on the overtube. I think the discussion is fantastic. And I too have actually ripped up piriforms, even with properly sized overtubes when they're tight. But I think an important point is to also know that you're not using a stomach one when you want the esophagus. Because once you get the scope down there, if you're a little less experienced, you're pushing and you want the overtube bumper kind of at the bite block, if you have a stomach one, you're going to just ram it down there, and you may cause damage with that. If there's a stricture, you may force the foreign body down. So I thought that was a great example and great case.
Awesome. All right, great discussion. Like I said, there's so much we can talk about with this very common problem. So thank you so much, Yu Yang.
Dr. Rubin had a question as well.
Oh, sure. Sorry, Peter.
I just wanted to comment that if you read the package insert on the overtube, it admonishes you to use a tremendous amount of lubrication on the tube. You have to really spend that extra time to lubricate the tube. And where I've been called upon to use it sometimes is by the cardiologists who want to do an esophageal echo in a patient with known esophageal pathology, like a Zenker's, for example, where every once in a while they'll perforate an esophagus trying to do a blind transesophageal echo. And these overtubes can be very helpful to cover the Zenker's or whatever the upper pathology is, so that they can go ahead and do the echo. You have to make sure you don't put the overtube too far down. You just want to cover what you need to cover so you won't interfere with their transducers.
Yeah, we used a lot of lubricant, right?
All right, we're going to move on. Thank you, everyone. Stephanie, you're on.
Perfect. Thank you, Chris. To everyone I don't know, my name is Stephanie Rutledge, one of the second-year fellows. You're very welcome, and it's nice to meet you. Today I'll be presenting a case which we saw on consults just a week ago, actually, with Dr. Greenwald again. And so this is the case of an 82-year-old gentleman with a history of coronary artery disease, a remote coronary artery bypass graft in the 80s. He is on aspirin 81, and he presented to his cardiologist with decreased exercise tolerance for several months. He was found in the office to have an iron deficient anemia with a hemoglobin of 6.4, which had been 11.7 just a few months prior. And so his iron studies were checked, which showed a ferritin of 4 and a transferrin saturation of just 2%. He had not had a prior endoscopy, and he did not use any NSAIDs. And his last colonoscopy was done in 2012, and it showed a tiny TVA, and he was told he could stop doing colonoscopy screening after that. He was seen by our team inpatient, and when we spoke to him, he reported that he had been waking up with worsening heartburn for the past few months. And he had actually started taking a PPI several days prior, which had really helped. He denied any dysphagia, weight loss, or any overt GI bleeding. And he had a chest x-ray done a few months before, which had shown an enlarging hiatal hernia. In the hospital, his hemoglobin responds appropriately to transfusing red cells. And so this is his chest x-ray, where you can see the hernia here shown with the blue arrow. You can see a fluid airline just in the sort of behind the heart here. And so an EGD was done for him same day inpatient. And so this is what we found. So here we're actually sitting in the hernia. You can see the diaphragmatic pinch further down, and then the G junction up here. And so the hernia seems to be about 4 centimeters. And as you come in, something catches your eye on the right side of the screen, which I can just show you again right here. And so this is another, oh yes. So here's the video of the ulcer, which we found just inside the stomach at the cardia. And so you can see that it's cratered, very necrotic base, but no stigmata of bleeding. And so we decided to biopsy it. And so we took many biopsies to try and get some tissue because we were obviously very concerned that this could be a malignant ulcer. We did discuss whether or not it was a Cameron's ulcer, but I'll show you on the next screen that the location is a little bit atypical because the hernia is here, but the ulcer is just distal to that right here. And so we were very concerned about malignancy in this 82-year-old with its deep cratered ulcer and no NSAID use other than baby aspirin and no other risk factors for ulcer disease. His H. pylori came back negative on pathology. His CMV was also negative, and he had no malignancy on the biopsies that we took, and we took about 4 passes. He did have gastritis, and he had chronic atrophic gastritis and intestinal metaplasia, complete type. So that might have been his risk factor for malignancy, if indeed this does turn out to be malignant. Our plan for him is to repeat his endoscopy in 6 to 8 weeks. And if we still cannot find malignancy, we think that he probably needs an EUS at that point if the ulcer has not healed on PPIs. And so
Sorry, Steph?
Yes, Zoe.
Doesn't the second thing say that he does have H.
for H. pylori? I've actually just seen that now. I need to phone him back and treat him for H. pylori. Oh yeah, it's negative in the first, but you're right. All right, so maybe.
Well, I only asked just because obviously like it's a little less frightening, right? If he does have at least one risk factor.
Definitely, that would be good. So I'll treat him for H. pylori now that I've seen. It just was the last line. And the other risk factor that I thought was maybe if he has atrophic gastritis, which is a risk factor in and of itself for malignancy, and the intestinal metaplasia. Although it's interesting, if he has atrophic gastritis, I'm surprised he makes any acid, because I think typically they don't. So I'm not sure how much the PPI is doing, but I will definitely treat him for HP now. Thanks, Zoe. And so my discussion, which at the end will open up for questions and more points from the audience, but to talk a little bit about malignant gastric ulcers, because that's what we were very concerned about when we did his initial endoscopy. And so our initial data date back to the 70s and 80s, and there were case series at those times, both from the UK and the US, suggest that about 14% of gastric ulcers are malignant. And predictors include the size of the ulcer being more than 1 centimeter in diameter, as well as male sex. A barium meal, which is what they used at that time, and it's more here for historical interest, was unable to distinguish benign from malignant. And the study that I looked at from 1980 suggested that the ulcer site, so the location of the ulcer in the stomach, and having coexisting duodenal ulceration was not predictive of malignancy. They found that the most common presenting symptoms were the same in both benign and malignant ulcers, being dyspepsia and anemia or GI bleed. But for malignant ulcers, these symptoms, so weight loss, anorexia, nausea, vomiting, and having 3 or more symptoms, were all statistically more common in the malignant group. Another study later on showed that in fact, ulcer location does help predict whether or not the ulcer is malignant. And I think this makes sense. And I think most people would agree with this. Malignant ulcers are more likely to be in the body, whereas the benign ulcers tended to be in the antrum. And so they looked at over 14,000 EGDs, 276 of them had gastric ulcers. And again, you see, so antrum is less likely to be malignant, shown in the darker box here, more so the remainder are benign ulcers. Whereas if you look at the corpus and the cardia, the malignant is higher than the benign gastric ulcers in each of these. And the angularis is more likely to be benign. And so looking at our patient specifically, his ulcer was in the cardia. So that has, in their study, about a 74% chance of being a malignant ulcer. And so then I wondered about doing the follow-up endoscopies for all gastric ulcers. In my limited GI experience, I've recommended doing a repeat endoscopy in 6 to 8 weeks if the ulcer is in an atypical location, or if it is in an atypical gastric location based on sort of what common practice seems to be at our institution. And so I looked at a study of gastric ulcers that were followed up with surveillance endoscopy. So 148 gastric ulcers had a relook EGD. 107 of them were followed to full endoscopic healing. And that actually took 2.7 endoscopies per person or per ulcer. So it's not just one and done. In none of these cases did they find a cancer that they didn't suspect on initial EGD. And so there were 41 cases which had not fully healed on repeat endoscopies. And so what did these end up being? Well, one had lymphoma, which they had diagnosed at the index EGD. One had pancreatic cancer, which they diagnosed on XLAP. And then 2 of them had non-healing ulcers, so they went for surgery, and both of them were found to be benign gastric ulcers on the explant also. Of the 37 who had not fully healed on their EGD, repeat EGD, they had all improved to minor erosion or erythema, and they were followed up for somewhere between 4 to 8 years, and none of them have developed gastric cancer at the time of the end of the study, at least. And so I thought this was important because we are often routinely following up gastric ulcers for surveillance, even when we're not so suspicious that they are malignant. And this study shows that if the endoscopist is not suspicious of malignancy, then following it up is unlikely to change the diagnosis, especially if biopsies, this wasn't shown in the study, but in my opinion, especially if biopsies are taken extensively at the first EGD. And so this is from the same paper, and they looked at all the people diagnosed with gastric cancer over 7 years. That was 67 patients. And they looked back at their EGD before the diagnosis. And in the majority of cases, over 90%, the endoscopist suspected that this was a gastric malignancy based on the macroscopic impression alone. So the report stated this is likely to be gastric cancer. One additional case was diagnosed by biopsy, which the endoscopist had not been suspicious of. And when you put the biopsy and the endoscopic impression together, you were diagnosing nearly all, over 99% of gastric malignancies. There was just one that was missed. And so the accuracy of biopsy and the endoscopic impression is high for malignancy. And so where do we derive our guidelines? How do we guide practice and what we're doing for these gastric ulcers? There's no US society that has recommended routine surveillance of gastric ulcers, but it is common practice. And a cost review analysis found that a quarter of patients with a gastric ulcer undergo a repeat EGD within 3 months. And I think the bottom line is that it's going to be an individualized decision. If you have a young patient with NSAID use, then if they have a typical antral ulcer, then they may not need a repeat EGD. You could treat them with a PPI and see how they feel. Like a 25-year-old who is popping a lot of naproxen for shoulder pain, I'm not sure that person, I don't think it's cost effective to bring them back for a repeat EGD, although from a medical legal standpoint, I know that this is done very often. The guidelines suggest that we could consider surveillance EGD if the ulcer is endoscopically suspicious, even if the initial biopsy is benign. And that's because there's falsely negative biopsies in about 2 to 5% of malignant ulcers. For going back to our case, I am somewhat reassured by the H. pylori, which was pointed out to me during the presentation, and the fact that that is quite a low false negative rate of malignancy for ulcers that are biopsied. So I'm hopeful that when we go back, it will not be malignant and it will be healed. The final word is that from the guidelines from the AGA is that any unhealed ulcer after 8 to 12 weeks of medical therapy should be biopsied on EGD. And I think that we're doing this routinely. I think maybe it's a good idea to biopsy on the first one too. Sometimes during a GI bleed, there's some hesitancy to biopsy, but I think it's useful to biopsy first up. And I'm pretty sure that if people are going back in to do surveillance EGDs, they're definitely biopsying. I think the time frame is important. I have been sometimes erroneously saying to do an endoscopy in 4 to 6 or 6 to 8 weeks, but I think it's important to give the ulcer some time to heal. So 8 to 12 weeks is what's recommended. And so with that, I would like to open up the floor to any questions or comments from the audience. I think Dr. Rubin has another question.
It points out how important it is to take biopsies in different parts of the stomach when you're looking for H. pylori, and not to mention reading the whole report. It also, I wondered whether on your picture, your close-up picture of the ulcer, is there a visible vessel buried in there somewhere that looked like there's a spot, a purplish spot? Maybe I'm not seeing it well. And the final question to you, Steph, is what are you going to do when you look back in there and it's maybe a third smaller? Or what are you going to do?
To answer your first question, I see what you mean. When you get up closer, it's a very clean based. Maybe that's one of our biopsy sites. I don't know if that was before or after our first biopsy, but when we had a closer view of it, I think that maybe that was it there, like a little bit of discoloration, but nothing that we could see that could be treated.
But do you biopsy right from the base of the ulcer or from the perimeter? Where's it best to take the biopsies?
The perimeter is where you're more likely to get viable tissue, I think. So I biopsied around the edges, all around here.
Yeah, that's correct. Peter, that's where you would biopsy, right?
Yeah.
Yeah, and there was this was the cleanest of clean-based ulcers. It just was all white and necrotic.
To answer your second question, what to do? I mean, I think in an ideal world, I would love to do the EGD and have advanced endoscopy on backup to do an EUS so that I don't have to bring him back twice. I'm not sure what other people would do, or because I think that is there's a significant chance it'll be smaller but not healed, and it would be nice to put it to rest, but I'd love to hear what other people think.
Brian, you had some comments you were making offline you want to share?
Okay, sure. I think that if the patient has no acid in his stomach, then I'd be more concerned that this is related to the hiatal hernia. I mean, I think it would have been easy just to do a pH on the stomach when you do the endoscopy. If it's got no acid, there's no role for giving him a PPI. It still looks like a traumatic ulcer from the big hiatal hernia.
Yeah, that's what I was going to ask you. You think the location, because the location looked a little bit too distal, but I would love to blame the hernia. Do you think it's possible?
It's definitely possible. This is the cause of that. The hernia is the cause, and you should have the hernia repaired.
That being said, this is not what a typical Cameron's ulcer looks like.
No, it's definitely not a Cameron's ulcer. This is a traumatic ulcer. This is not a Cameron's ulcer.
So the pathophysiology is that it from the hernia reducing in and out, that it's causing trauma, or?
That's supposed to be.
Okay. Well, we will let you know. Yeah.
This is Steve. I have two comments to make. First of all, the biopsy that showed atrophy was from the antrum, I think, was it not?
Yes.
When you're looking at achlorhydria, you're looking at atrophy of the proximal stomach, not the antrum.
Right.
So, he may well have acid because the atrophy is not in the proximal stomach. And the other thing to always remember is, of course, we worry about gastric adenocarcinoma, but this could be a malt lymphoma from H. pylori. So you always have to, bear that in mind when you're doing your follow-up endoscopy.
I will say that there's a handful of really painful EUSs that get referred to us. The refractory gastric ulcer is probably sort of high on the list, next to a small lump in the submucosa of the duodenum. Mostly because I don't think I've ever found much on an EUS of the gastric ulcer, because it's very hard to differentiate a early malignancy from a benign ulcer, because they look the same on EUS. You get some changes into the wall, into the submucosa, unless you see really advanced disease, like penetrating through the muscularis propria and lymph nodes. EUS is sort of similar. And of all the ones that I've done, I don't think I've ever found a cancer on a EUS for an ulcer. If I've ever found a cancer, it's because I biopsied it aggressively. A lot of these ulcers are slow to heal, but I'm always surprised by how many of these patients are on low dose PPIs. So they'll come to us 8-12 weeks later, or maybe longer, and then I find out they're on 20 milligrams a day of Nexium. And when you move them up to a high dose BID, you get much better healing. And so that's just sort of my own experience. I don't know if Andy or Chris or Nikhil have any thoughts.
I would agree with you, but I would say there's enough of a hit rate that it's still a relatively quick and easy thing to do. And maybe 1 out of 10, you'll find a cancer there. But I agree with you. I think the majority of these tend to be benign. It tends to be sort of a not exciting endoscopy because you're trying to prove, it's hard to disprove something because they, like you said, they look the same.
Yeah,
you can always do needle biopsies of the wall and if when in doubt.
I agree with you guys there on the EUS. I think it's important to note, back when Chris and I were fellows, the standard was 8 biopsies of the ulcer edges, and I think that might have come from a paper from Coachman in the past. But I actually think it's important for the fellows especially to start getting used to NBI and other optical enhancements that are commercially available on your scopes, because this is an area, this ulcer, we don't see the NBI here, but the white light looks pretty benign. And the sensitivity and specificity is very high, even without magnification. I just moderated a session for DDW, pre-recorded 2 days ago with Professor Sano, who invented NBI for Olympus. And actually, I think it's important we get used to NBI, but they're actually at the stage of endocytoscopy, where he can magnify to the level of the cell. And so, with AI coming for diagnostic applications, I think it's important for us to kind of be able to double check the computer. So I think NBI here would help. And that also may augment your ability to look at the stomach and look for other areas of metaplastic gastritis, which is important.
All right. I want to be respectful of the time, so we have one more case. So again, another case we can just sit here and debate all day. So thank you, Steph, and thank you everyone for the discussion.
Thank you.
Our last case is going to be Nick. We'll turn it over to him.
All right, thank you. This one will be quick. So this is a case of a difficult polyp. The patient was a 71-year-old female referred for colon polyp resection. On her index colonoscopy, she had a 3.5 centimeter polyp at the hepatic flexure with attempted resection, which was incomplete. And then she was referred here for further management. On repeat colonoscopy, there was a residual 2.4 centimeter polyp that had a non-lifting sign. So based on that, EMR was not attempted, and the decision was made to attempt full thickness resection. So before we go into the video, just so you understand what you're seeing, because there's a lot going on and not a lot of visualization with this device. This is the full thickness resection device. It's a very large cap. The cap itself is actually over 2 centimeters in length from the edge of the scope, and about 2 centimeters in width as well. There's an over the scope clip loaded onto the cap, and there's a snare also embedded in the tip of the cap. So the way that this works is you advance the cap to the lesion. You can use a grasping forceps to pull the lesion into the cap. The recommendation is that you do not use suction, because if you use suction, you can actually pull too much tissue or even adjacent organs theoretically into the cap, which would be bad. So grasping forceps alone, the lesion is pulled in. And then the way this resection works is you can see the layers of the wall in this sort of schematic diagram. It pulls the full thickness of the wall in. The over the scope clip closes that area prematurely, essentially, to prevent a full thickness perforation. And then the snare makes a full thickness cut. And so that's what we're going to see in the next video here. So this is the large polyp. You can see it's located on a fold, very difficult location. The lesion is marked. This device also comes with the whole kit in order to ensure that you have a good margin around the lesion, because again, visibility is not great. Once you have the cap on, it's hard to see the lesion, but you can see the markings. So this is the cap. The grasping forceps is advanced in to grasp the lesion. The lesion is pulled inside, and then once we get the lesion, it all happens pretty fast. There's a lot of coordination between deploying the clip and then using the snare to snap the lesion without it sneaking out of the cap in between. So that's the clip deployment when the white goes. And then the snare, you don't really see much, but that was a hot snare that happened in the middle. And then this is a good view of the resection. You can actually see the full thickness of the muscle and even potentially some serosa in there. And then the clip in place with no perforation there. And this is the lesion pinned out. So it was a full resection. The pathology ended up showing tubulovillous adenoma with no invasive carcinoma. So a good outcome. So just to go over the full thickness resection device a little bit, it's approved for, this device specifically is approved for colon lesions. It would be very difficult to advance in the upper GI tract anyways, just due to its size, but it can be used in lesions 2 up to potentially 3 centimeters in size. In a non-randomized prospective study of the FTRD in the colon, and they looked at a subgroup of 127 patients with difficult adenomas, and the device was successful in 92%. R0, which is an oncologic resection with negative margins, was 78%. Of course, that number is not as relevant in the adenoma category, but they also looked at early cancers and subepithelial lesions, in which that would be a more relevant number. And we can't even report an R0 with normal piecemeal EMR. So this is a unique factor of the FTRD device. There was residual still, despite this, in 15%, which was able to be managed endoscopically in a majority of cases, and 3 cases out of that whole group needed surgery for these difficult adenomas. Notably, although we say potentially up to 3 centimeters in size, the success rate was significantly lower with lesions that were greater than 2 centimeters, and almost 100% successful in lesions less than 1 centimeter. Adverse events are reasonable. There's a risk of bleeding up to 3%, perforation, immediate or delayed. A small number of these patients ultimately did need surgery for complications. It was a single-digit number of patients. And then there are a few unique complications to this device depending on the location of the polyp. Appendiceal orifice polyps can be resected with this device, but there's about a 20% risk of appendicitis. We've seen fistulas from full thickness resection. So there are some unique considerations depending on the location of the lesion. And I think we're kind of running out of time. We might have time for brief questions.
Nikhil, do you want to have a closing comment here?
Yeah, this was a tougher case because of the prior EMR. They had actually initially referred for ESD, but you know, when someone has had prior resections, or especially if there's a tattoo that's done right under a lesion, you know, either salvage EMR or ESD becomes a little bit more technically challenging because you require submucosal lift to do those procedures well. And so this device is really great for non-lifting, difficult to treat residual neoplasia after prior EMR. Just like a couple of comments in the last minute is that it is a unique device. As Nick mentioned, the closure aspect is performed prior to resection, which is usually the inverse of what we normally do in endoscopy. And then a couple of the limitations, it's pretty bulky. It extends a couple centimeters beyond the scope tip, and that cap with the large external clip can actually be difficult to navigate around angulated colons or ones with significant diverticular burden. And as you saw in the video, visibility is very coned because of that cap. And then there's a learning curve for this. It's about 15 cases in the literature to get a good grasp of this device. There actually is a gastroduodenal FTRD, which is out, and so that can be used for you know, scarred lesions in the upper GI tract after like EMR, ESD, and it also can be used for small subepithelial lesions that could fit within the cap diameter. But it's a good device that allows us to get full thickness, and it in general is safer than our traditional full thickness where we're cutting through the wall and then having to deal with closure either by clips or endoscopic suturing.
All right, beautiful case. Thanks so much, guys. Awesome.